chance that he's a 10 out of 10 match.
Okay.
So I know, one of the things that we had talked about at the last consult, and that I think Amanda had been very concerned about, was the availability of a suitably matched donor.
That was one of the reasons I was given.
Yeah.
So,
there are these two additional options. It is really, I'll tell you the pluses and minuses for both of these. So the first is that we always take degree of match over anything else when we're selecting a donor for the transplant. So if we have a 10 out of 10 donor, we would use that over a 9 out of 10 donor. We would use that over a parent who's a half match.
Yeah.
Okay. The issue with donors is that the older that the donor is, the higher the risk for graft versus host disease from that donor.
Okay.
There is also a higher risk of graft versus host disease when we transplant a female into a male compared to a male into a male.
So the 6 out of 6 might be better than the 10
Yeah,
out
so
of
the
10.
32-year-old male would probably be a much better option for him than the 53-year-old female.
Okay. And that's a 6 out of 6, but could be a 10 out of 10?
It's a 6 out of 6, and there's a 65% chance that he's a 10 out of 10.
Okay, it's like the 6 out of 6 is like the preliminary match or something?
Yeah, so when we're talking about 6 out of 6, there are 5 different places that we try to match. We call them A, B, C, DR, and DQ. And you have 2 alleles in each of those spots, one from your mom, one from your dad. So that's 10 total things that we're trying to match. When we're talking about 6 out of 6, we know that they match at A, B, and DR, but we don't know about C and DQ.
Okay.
There's a lot of statistical stuff that we can do because we know that if you match at those 3 loci, it's very, very probable that you also match at the other 2 places, which is why we say that it's about a 65% chance.
But you wait to go and do any more invasive.
We can't request the additional testing on that 32-year-old donor until we have insurance authorization to move forward with the transplant. So that is one of the reasons that we kind of need to know from you guys whether you are going to move on with that transplant, because if that's the case, we can activate that donor and we can have him come in and we can do additional testing. But
I'm all for that, but it takes Amanda and I, and as I brought up on the phone, she's still under Dr. Ambrusso's impression of it's 1980 and you're doing a BMT.
Yeah, well,
and she just...
I know that, and I don't know if you've talked with Dr. Ambrusso lately either.
I haven't.
So, it may be helpful for you to talk with Dr. Ambrusso because, the last time that I discussed with him, and he actually saw Amanda and Sean at the last clinic visit, Sean had participated in one of Dr. Ambrusso's research studies probably about a year ago to look at how people respond to interferon gamma, and Sean didn't really have a response to interferon.
Okay.
And then the new IBD situation, I think that Dr. Ambrusso is actually thinking that the combination of his poor response to interferon and the new kind of development of the IBD, he objects less, honestly, to transplant than what I think he would have in the past.
My issue that I run into, or that I'm experiencing, that I'm hoping doesn't become a trend, is it seems like every 6 months we're on a new medication. But it's not a new medication for CGD, it's a new medication for a side effect. So that's my concern, that he's going to be 13 and we're on 30 different more meds, and all of a sudden we're just playing catch up, responding to side effects instead of solving the issue.
So I will tell you, and I think that we discussed this kind of in the consult the original time too, was that usually for transplant for these unrelated donor situation, or for these genetic conditions, not malignant conditions, it is always better to go to transplant sooner rather than later, primarily because as you develop more and more complications from the disease itself, it makes transplant harder and harder to do, and the outcomes are not as good. I
Just
will
being
tell
full honest and full disclosure on this, if we're going to go forward in any way, shape, or form as of right now, it's going to be dependent on what Amanda hears from you.
yeah, so I can only.
I could tell her all of this, I could show her all of this, I could give her a copy of all of it. It came from me, it's poison, it's tainted, she won't touch it. So it has to come
Yeah, so
from the doctor.
and here is the situation
Yeah.
from our standpoint. So we would be happy to talk with her if she wants us to talk with her.
Yeah.
We cannot compel her
Oh, I
to
know,
come to a visit.
I know that completely.
And the other thing is that with these non-malignant transplants, what you are swapping out is the risks of what is going to happen when he's a young adult
Mm-hmm.
for a very real risk of upfront mortality where he could potentially die
Mm-hmm.
within the first year of the transplant.
Yeah.
And so that is where it is very difficult, even from a legal standpoint, to compel anyone to do a transplant because this is not immediately life-threatening.
On the legal standpoint on that, if I have to go that route, I'm going on neglect, and I'm going to get medical rights given to me. That's what I will be going for, legal standpoint, because I have 3 years now of videotape and photograph proof that she does not give him his medication.
Yeah, so
So that's
we are happy to move forward
Yeah.
if all parties who have medical decision making
Okay.
are on the same page. What we can't do is go against the wishes of someone who has medical
No.
decision making capability.
I get that, but I guess my next place would be, what kind of medical documentation can you provide for the courts for me to go that route? Because they're going to look at it and say, oh, well, do we have a match? Do we this? Do we that? Before I take the rights away from her, what's going on?
What you can do is you can request through the medical records office at the hospital a copy of basically any of his medical records, so that includes
Now, would
every
that
single.
have all the BMT stuff as long
Yeah,
as
so
with
I
somewhat of a
wrote-
formal recommendation?
I wrote
or
a
is
very
it-
comprehensive consultation. I forget when we met initially. Was it about a year ago?
Been a couple years, I think.
So, there was a very comprehensive consultation which goes over the risks of CGD, the potential benefits of transplant. We will update.
Mom called and she apologizes. She said she has a sore throat and a headache and does not feel good. So
Okay. We can have Allison touch base with her and see if she would like to reschedule at a different date and time.
Okay, perfect.
Yeah, because I'd like to both of us be here. Because, like I said, I was hoping for her to be here today, and if she was, my main goal ultimately is to get me and her on the same page. Because here's what I experienced is, since our last consult, she's given me a dozen different medical reasons of why we're not doing it. I've asked you about every single one of those, and they were complete miscommunications, misinterpretations. She's convinced that BMT's 67% chance he's going to die. No ifs, ands, or buts. That's her solid ground. But from what I got from you, that is not the case.
Yeah, no. So with the European transplant protocol, if you have a well-matched donor, the outcomes are 90% or better at 2 years that you are alive and cured of the CGD.
Yeah.
If you do not have a matched donor, that is harder for us to tell, and that is because there's less data basically available for it. We know from a lot of different conditions that if you use a haploidentical donor, so that is someone who's a half match who's related to you like a dad, that those outcomes can approach a well-matched unrelated donor. If we take some additional steps and precautions like administering post-transplant cyclophosphamide. If we give a cord, which would be Sean's other donor options. So he has several
Doing cord blood.
cord bloods. He has some 6 of 8 cords. And the match on a cord doesn't matter quite as much as the match on marrow, so it's okay to be mismatched at a couple of different spots in a cord. We have to make sure that we have enough cells in that cord to give him a good cell dose. And when you start having double mismatches in your cords, your risk of graft versus host disease does increase a little bit. So I would choose this 32-year-old if he were available.
Okay.
The other thing that I will say is that when we are looking at these donors,
They change.
just because they are in the registry now does not mean that they will be in the registry later. If we called him and activated him and tried to get him to come in, he may say, no, my life has changed. I either am not medically eligible to come in or I don't want to come in anymore. So there's no guarantee.
I guess in our book, though, on average, how many patients do you have that would kill to have a 6 of 6 match or a 10 of 10? Is that something just great for us? Is it rare, or is it pretty common that we're able
I'll
to
tell
get
you
these
that
types of matches?
his donor search is not as good as most people's donor searches.
Okay.
And the reason for that is that when we do donor searches for a lot of people, we have multiple 10 of 10s that we are able to choose from. And really what we're doing is we are choosing the best of the 10 of 10s using some minor criteria like blood type or infectious status, whether they're CMV positive, etc.
Okay.
Or based on age. So the fact that he really has 1, potentially 2 10 of 10s, that is not as good a donor search as we normally find.
Okay.
The other thing is that we have to have a backup option for the transplant. So we cannot just have a single donor and plan to move forward with the transplant, because if something happens to that donor after we start giving the chemotherapy, we are stuck.
Yeah.
And that is a very dangerous situation to be in, because we've removed his immune system, but we're not giving any new cells.
And is that why we would more likely go to cord blood? From what I remember our last consult, that was the way you were leaning, was cord blood, based on what we had then.
Yeah, so I would choose this 32-year-old if he was available and potentially use a backup cord. If we absolutely had to. The chemotherapy that we give is probably slightly different, and when we do have a cord, remember that there is an increased risk of rejection.
Yes.
So that we could go through this whole thing and his old immune system grows back and he still has CGD. Or a more dangerous situation where no immune system comes back and he doesn't have CGD, but he just has no immune system because of the chemo. So that's where we are.
Statistically, is that a frequent occurrence? Very rare?
It's a 5 to 10% chance. So, there was a series of 13 patients who had cord bloods done at Duke, and I believe that they had 3 rejections. They were able to salvage all of those patients with a second transplant.
Okay.
But there is always a risk when you do a second transplant that you could, have more severe complications. And there is really this issue that with second transplant, even if you give another cord, that you have then had no immune system for a much longer period of time, and you can develop fungal infections, so those risks start to really increase very rapidly. I will be very honest with you.
Please.
There are definitely risks associated with the transplant.
Okay.
We have transplanted a couple of older patients with CGD this year.
Okay.
Because they had really severe infections, and they had no other option. They were going to die from their infection if we did not transplant them.
Okay.
One of them did pass away during the transplant process, and one of them survived transplant and is doing very, very well.
Okay.
I don't know if this is more of an illustration of why you should go to transplant before you develop these severe complications and infections as an adult, but I think it also illustrates that it is a very real risk going to transplant because you can die during that procedure.
It does. I guess my concern is, where is Sean on the spectrum of average CGD patients when it comes to infections, complications?
Yeah, so
If you could do a forecast of Sean, is he gonna be a hospitalized teenager until we have to do a BMT, or?
So we can't tell whether he's going to be a hospitalized teenager, and the data for CGD is that over 95% of them are going to make it to age 20.
Yeah.
So probably he's not going to have issues as a teenager. The issue is when we start looking at how much residual function. So CGD is a defect in an enzyme, and that NADPH oxidase, which basically allows his neutrophils to make a chemical that can destroy bacteria and fungus. And we know that there are different types of CGD, and that the different types of CGD, you have different amounts of that enzyme that still work, and different amounts of that chemical that you can still make. Patients who have X-linked CGD, like Sean, who have no oxidase activity, so he would be in the bottom 20% of patients with CGD, that they have a median survival of 30 years based off of the NIH cohort. And so that means that half of patients will die by the time that they turn 30. That also means that half of patients will survive to be older than 30. And we don't necessarily know kind of how old the rest of those patients live. But I will tell you, I have patients, because I have patients whose grandfather had CGD and was old enough to, have children of his own and lived into his 50s with X-linked CGD. So, we cannot say for sure what will happen to Sean, but we can say on average, people with his degree of dysfunction, half of them will die by the time that they are 30.
That's one thing I got from our last consult that Amanda and I are not on the same page about. She adamantly disagrees with that. No, they live to 60, period, as long as we give them shots. There's no, but I digress on that. It's tough, I know that, but I mean, fuck. I know Sean, I see him, I know the issues, we bust ass on his hygiene, we try to keep him, but it's just impossible to keep him clean, to keep him out of infectious situations or potential, it's just, it's hard, living every day of a life now. Oh, you can't do that. Oh, no, we can't do that. Oh, Emma can do that, you can't. There's that, but I mean.
And what we find oftentimes is that compliance with some of the prescribed therapies really declines when people become teenagers and young adults.
That's my other concern.
You don't have a parent who's going to force them to do those things anymore.
And with us being split and in different households, and it's like he hasn't taken. We need to get laxatives filled again, I guess, because I refilled them. We've gotten into a good routine where I refill all the meds and she picks them up. That's the only way we don't run out. But when she goes to pick them up, if they're not there, she won't get them. And then here we are 3 weeks later. Oh, he hasn't had that pill. And that's a constant. He's always short one medication all the time because she's busy or was out drinking. She got too much going on. I don't know. But I'm just.
So
it's tough, but I mean.
So I understand that that's super frustrating. What I will do is I I will encourage you to go to medical records to sign whatever paperwork you need to sign to get copies of his clinic notes.
Yeah.
And specifically, you can request the BMT consult from whatever day that we had that consult initially. I will write an updated version today.
Please.
It will probably take about a week for that to be available, so you may want to wait for medical records requests for about a week,
Okay.
which would basically just update the donor situation and the fact that he has that new complication with his inflammatory bowel
Okay.
disease.
That's, like I said, I brought up earlier, it's concern is it seems like we're treating side effects and not the disease right now.
Yeah, so all of this is going to be part of the disease. We know
Yeah.
that patients who have CGD have autoimmune problems like
Oh, I
inflammatory
know,
bowel
but
disease. and
we're
also
doing
develop
laxative
lupus.
to help him loosen up, and so what's long term? He takes laxative for 5 years. Is there any type of long term damage that
So there's
constantly taking stuff like that? Or
there's no issues with long-term laxative use.
Okay.
What there is that if you have inflammatory bowel disease, it is very difficult to grow and gain weight, which I know that we've already seen with Sean.
Oh, he's eating now. Those appetite pills are a lifesaver. Oh
Um,
my God, he's eating. That's such a stress.
The other issue that can happen with uncontrolled inflammatory bowel disease is that it can increase your risk for things like colon cancers. So instead of getting those when you're in your 60s or 70s, we do recommend earlier initiation of colon cancer screening in patients who have IBD.
In general, I guess I know it's not a one size fit all answer, but BMT, is it preferred when they're young or when they're older, or is it really just per case? I mean,
It's preferred when they're young, especially if they have the X-linked form of CGD with no oxidase production, which would be Sean's case.
now then you have
I
the
will tell you.
not reacting to the gamma interferon.
I'm sorry.
He said he doesn't react to the.
So yeah, and that is not data from a CLIA approved lab, so that is not part of his medical record.
But it's
But that is, basically the data that Dr. Ambruso was able to obtain,
okay.
which basically showed he didn't really respond like other CGD patients to the interferon.
Okay.
So, the other thing that I will say is that things change over the course of many years too. So, gene therapy is not really an option for CGD at this point, but gene therapy could be an option over the next decade for CGD. And
I guess my question on that is, 5 years ago when we were first diagnosed, it was the same thing. It was gene therapy. It could be next year. And here we are 5 years
I'll
later,
tell
and
you
we're
that
still.
it's
It could be.
It's definitely not going to be next year.
Well, I know.
because
I'm
it's
just
not
curious
open
of their realisticness. Even if they have all the breakthroughs, there's still years of regulation and everything before stuff could go into effect.
Yeah, so I'll kind of tell you from another rare disease standpoint, because I also transplant patients who have sickle cell disease.
Okay.
Is that the first gene therapy for sickle cell disease was done in 2014 in France, and we are looking at potentially having gene therapy authorized for commercial use next year.
Okay.
So that is 7 years, right? So based on the technological advances, because we have been able to make a lot of progress with the type of viral vectors that we use for gene therapy, or even CRISPR, which is now kind of increasingly being used in some patients. That is a possibility. And for someone who does not have a donor, that is a person who would go to gene therapy, because what gene therapy does is eliminate the risk of graft versus host disease. Because you're taking his own cells, he would serve as his own donor. You fix those cells and then put those cells back into him. That is not available for him right now.
Yeah.
I honestly don't even know that there's a clinical trial for this right now.
I thought I read, I swear I seen something on a CGD gene therapy. Maybe it was from NIH or
Yeah, so it was from
maybe it was
NIH
Australia or
a
something.
while ago, and then they had halted that trial.
Okay.
I don't know if it's because of efficacy or what, but I don't know of any place that's actively accruing
Okay.
for CGD right now.
So that's
So that
merely just a possibility in the future.
that is
It
merely
might
a
not even-
possibility in the future, but something that you may want to consider waiting for if if this risk profile is not acceptable because of the donor availability.
Okay.
Because, and I know during the first consultation we talked a lot about graft versus host disease,
Yes.
and what we don't want to do is exchange one disease for another disease. And if you get bad graft versus host disease, that actually it can really decrease your survival for patients who go through transplant. The other thing would be that I just had an adult patient who was in his 30s who got transplanted at NIH.
Okay.
So they are doing some transplant in adults using reduced intensity conditioning, which basically means lighter versions of the chemotherapy,
Okay.
usually because the adults have had complications already and can't tolerate the same doses of chemotherapy that we give to children. They are making advances in how to treat adults who have this disorder and disease.
Okay.
And so that may be something where we don't have all of the data yet to say how that's going to work, but could also potentially be an option for him in the future if he got to that point where he was starting to have lots more complications as an adult. My recommendation is still go before you have those complications if you have a suitable donor. If we have this 10 of 10, 32-year-old donor, I would probably recommend going.
Okay.
If we did not have a suitable donor, then that is really more of a joint decision making that has to happen with the family about what your risk tolerance is and whether you're willing to accept upfront risk that he dies in childhood, right? Versus preventing complications and him dying in adulthood. So that really is something where I can't say this is what you
It's
absolutely
kind of,
have
even
to
though numbers will fluctuate, it's kind of a 90+% chance of doing a BMT and surviving now, or a 50% chance of
Dying
living
at
past 30.
Yeah, and for some people, they would say, yeah, that's like 25 years that I would love to have. And it would be really hard for me to say, yeah, there's maybe a 1 in 20 or 1 in 10 chance that I die now.
Yeah.
There's a lot of people who would turn that down.
Yeah, and I'm open to that. I'm trying. I just wish Amanda and I could. We just don't communicate, which is why we got divorced. But I just wish we could. So much of our last 2 years of stress over this has been misunderstanding. It's been misinterpretation of the information, because it's not what was in the book. It's not what I've confirmed with you. And so I'm trying to be sympathetic that this is what she's basing her decision off of, but she's not giving me any facts. She's not giving me anything that matches what was medically said. And that's what's pushing me into a corner. And just with the constant issue of medication, I know he doesn't get them still. There'll be days where, oh, mommy, let me have it off. And I'm like, okay, so you haven't had a shot in a week and a half? Because it's not that she doesn't have it. That's my concern, is that she's going to be too busy with her life, which is fine. But if she's too busy to, simply give him his medication, that's my concern, is that a lot of this data is based off of, yes, providing we do his preventative care. But if we're not on top of his preventative care, It's like freaking playing Russian roulette with a dirty needle for him. Yeah. Yeah.
So we are happy to reschedule with her, if she would like to reschedule, and I'll have Allison Clifton, our nurse coordinator, kind of reach out to her again and see when she would like to reschedule.
Yeah, I
And I'm happy to go over, some of the same information with them.
I think a big thing is Dr. Brusov was our original doctor, and I remember specifically from him our early on meetings were no, just BMP, nope, not going to talk about it, not going to think about it, it's not in the works, it's not in the cards, it's not for Sean right now. But again, different doctors, different times, different experience,
And what I would encourage you to do is just talk to people from the CGD patient groups too,
Yes.
and figure out what their experience has been and what went into their decision-making process, because like I said, this is really an individual decision that individual families have to make based off of what their risk profile and tolerance level are. And so that would be something we would encourage you to talk with them about. At any point, if you wanted to go for second opinion somewhere, we would for sure be able to facilitate you talking to someone else. We actually have a new immunology group here at Children's, with 4 or 5 different immunologists as well, who, if you would like to discuss with them and figure out, what their recommendations are, that we would be happy to have you see. So that would be something that.
Can we get that set up maybe when Amanda does follow up?
So I don't schedule. I don't coordinate or schedule for them, but we can definitely. And what kind of insurance is it that you guys use?
It's under Medicaid for Amanda.
Okay.
And if Medicaid doesn't do it, it'll be under Veterans Affairs.
Okay. So I could just email one of the immunologists and say, hey, would you be willing to meet with them? And I would let them take care of scheduling with you guys.
That would be good.
And that way you can kind of get some outside input as to whether you think that this would be useful, because they'll go over kind of some of the same